And thank you for the historical uh, reviews we have just heard. They are absolutely amazing, and it's amazing to see how we have uh, moved so far in such a period of time. And I've been enjoying every minute of it. From the first case I had in 1967 as a resident, stimulated by visits from uh, Dr. Guillot and the lectures of Dr. Hardy when we started the first of these 6,000 transsphenoidal operations. Um, Now I need to advance my slides, and I'm not sure how to do that. Here we go. Yes. So staying out of trouble seems to be one of the most important things these days for those of us who are still trying to pioneer the transsphenoidal approach to the skull base and all of its problems. So most important, do not stray from the midline because you can have a carotid or a cranial nerve injury. And keep your orientation, superior, inferior, as well as lateral, because of transgressing the cribriform plate or even the clivus. Dealing with bleeding and its control in a very confined area using the endoscope and other instruments that are never perfect for cauterization, and dealing with the spinal fluid leak and its control, and finally, later on, nasal and sinus problems. Other things that we deal with are hormonal issues, and particularly need to follow thyroid and calcium in some of our patients. We deal with diabetes insipidus, with the syndrome of inappropriate ADH secretion, and with hyponatremia. And all of these things can cause a wonderful operation to be a quasi failure. We see electrolyte imbalances, and we also see DVTs, and their prevention is an important part of our overall management of these challenging patients. Always remember that the endocrinologist is your friend and not the enemy. You recognize Georgi Murasan in the center, the acromegalic from Romania who came to the States and played basketball. And I operated on him, not only on his pituitary tumor, but on his lumbar spine, because he had facet hypertrophy causing an S1 radiculopathy and was about to lose his basketball pension. And so we removed his facets, and he regained his prowess as a basketball athlete. And the woman you see there is Mary Lee Vance, with an endocrinologist I worked with for 15 years. And I learned so much from her and her colleagues, and you must use them for your benefit. Now, remember that progressive visual loss is a real emergency, and it requires surgery. And this is a prolactin adenoma that caused, look at this vicious visual field deficit with the optic nerve and visual field compromise that was completely reversed when this tumor was removed. One thing before we go to surgery is we have to measure their pituitary hormones, and that was just mentioned recently, how important that is to what we do. So if patients are hypothyroid, they may need thyroid medicine. And if you give thyroid medicine to a patient who is impaired in the cortisol axis, you may precipitate an Addisonian crisis. So always give her hypothyroid carefully, slowly, and don't provoke a catastrophe. And also measure calcium, just to be on the safe side. We learned that packing the oropharynx and the nostrils postoperatively no longer is necessary. The precision of our surgery now completely eliminates these issues, and we don't miss them at all. So we learned also that a Foley catheter is not necessary. As Professor Fallbush mentioned, our operations don't take more than 2 or 3 hours, and so we don't require a catheter in all patients, and so I don't use them if we don't have to, and we don't use intensive care unit if we don't require that in specific cases that may have vascular risks. So we've gotten rid of some of the things that that really were traditional, but are no longer very helpful. We do not use routine spinal drainage, either intraoperatively or postoperatively. We don't believe that it is desirable or necessary in many patients, and it's especially not desirable in elderly patients who don't respond well to depletion of their CSF. So instead of putting in a catheter and monitoring the patient for weeks and clamping the catheter and trying to remove it and having it leak again, we simply take the patients back. Now, we mentioned the positioning of the patient. I think this is one of the things I teach most vigorously to our residents and our students. We position the patient so that the midline of the patient's head is parallel to ambient space, the midline of the room. We also flex the head so that the dorsum of the nose is parallel to the floor of the room. These are ergonomic issues that really make a difference in care and in avoidance of complications. And this is the arrangement of the surgeons when we do either microscopic or endoscopic surgery with the surgeon and one assistant. And we can manipulate the thorax elevation by moving the entire table and thereby decrease venous pressure if we want to go into the cavernous sinus or have excessive venous bleeding in the exposure of a tumor. Now, anatomy is always important. It is for every kind of skull-based surgery, and you need to understand and identify the landmarks that are anatomic and that keep you out of trouble. Most important is the vomer, which is a midline marker in almost every patient, the rostrum of the sphenoid, which allows you to enter the sphenoid sinus carefully without causing a spinal fluid leak or impingement on the carotids laterally. So it's very important to know the anatomy and to respect it with the surgery and do it every time and correlate what you see with what you have on your imaging studies, mainly the high resolution MRI or CT studies. This is from Professor Capobianco, who introduced me to the endoscope and made me certain that it was an advance in our care of these patients with pituitary problems. And here we see landmarks that we could not see with the operating microscope previously. Here's the sellar floor. Here are the carotid protuberances. Here's the opticocarotid recess, the optic nerve here. Here's the planum sphenoidale with the floor of the frontal fossa, and here's the clivus. So we can see all of these anatomic structures in exquisite detail and thereby avoid many of the complications that were such a problem when we began doing these operations. So I use imaging control liberally. I do it mainly so the residents and the students can see where the instruments are located and manipulate them themselves. We can check the angle of approach, the trajectory, the floor of the sella, the junction of the sella with the anterior fossa and the clivus. Again, these safeguard the patient and are important adjuncts to our exposure. Now, sometimes the imaging studies give us a feeling this might be a vascular problem. And so if an aneurysm is expected, and I've seen two of these behind the dura, we need to interrogate the dura with the microvascular Doppler, which our colleague Dan Kelly introduced. And if the Doppler sounds like a vascular lesion, beware. And then we will occasionally, if we think there may be an aneurysm or even a cyst, we sometimes use a fine needle to interrogate the dural contents. And I want everyone to remember that the dura has two layers of dura, just like every other part of the head. And between the two layers is a vascular chamber. And so you must get through both layers and make sure that the venous bleeding is controlled that you produce by doing that initial incision. Now, if the sella is enlarged, the trajectory of approach can be manipulated to take out even very large tumors. And so to do this carefully and in accordance with the image guidance and with what you see on your imaging studies, one can take out rather large tumors safely as the diaphragm comes down. Now, here's the typical opening that we recommend, primarily for microadenomas, but for all others. We open the sella from the dural margins, the cavernous sinus on one side and the other, and we take off the floor of the sella in most cases, and we expose the tuberculum sellae in most cases so that we know exactly where these anatomic landmarks are located. We know we might get a CSF leak if we go too far in this direction. We know if we might get bleeding if we go too far in this direction. So this is the prelude to the entry. Now, within the sella, one of the important things is to preserve the posterior pituitary function. The posterior pituitary has a unique position and a unique characteristic. For me, it looks like ricotta cheese. It's very fragmentary, and it's best not to remove it. But even more important is not to damage the axons of the pituitary stalk. These are the axons of the neurons in the hypothalamus, in the paraventricular and supraoptic nuclei. If you damage the axon, you get karyorrhexis, and the tumor bodies may die. And that is when you get permanent diabetes insipidus. So don't crush these axons, don't damage them, don't pull on them. And if you have to section them, do it sharply with a quick knife cut, hoping not to produce damage that will retrograde interact with the body of the neuron and kill it. Now, if you don't have a spinal fluid leak, if you don't have a lumbar needle and you want to push the tumor down, if it's a soft tumor, instead of putting in a needle and injecting saline or air, I learned from Ivan Chirek that bilateral jugular compression can produce enough intracranial hypertension to push a tumor down. So without the use of a lumbar catheter, if you simply send someone under the table to compress the jugular veins bilaterally, you can deliver a rather large tumor sometimes. I was learned to obliterate dead space when necessary, and we use fat grafts, sometimes with a few cotton fibers in them, and then reconstruct the floor of the sella. And if there's no cartilage or bone, we can use an absorbable plate. So we do reconstruct the sella in many cases, not all of them, but particularly in those when there has been an intraoperative spinal fluid leak. Now, in acromegaly, we know this is Cushing's first patient, by the way, when he was young and when he developed full-blown acromegaly, a farmer from North Dakota. In acromegaly, the bone is thicker, the blood vessels are larger, and the carotids are tortuous. They have dolichoectatic features. They can be calcified. They can have aneurysms. So you must be very careful. The distances between the carotids may be very small, and the distances for your tumor may be greater, and the instruments for the instruments may be longer in patients with acromegaly. More important is the anesthetic aspects of these patients, most of whom have obstructive sleep apnea from the acromegalic influence of the tongue and the oropharyngeal features. So our anesthesiologists often use awake intubation, endoscopic intubation, and it's very important to maintain a good airway in these patients. And another important thing about acromegalics is that they often look as if they have diabetes insipidus right after surgery because they have excessive urination. This, in most cases, is simply mobilization of interstitial fluid that is retained because of the excess growth hormone. And so if you give the patient a day or two, you may find that it is not diabetes insipidus. It is just a very good response to lowering growth hormone. Now, with prolactinomas, we always discuss with the patient that we have dopamine agonist medications that can lower the prolactin in most cases. If that works, if the patients have a good response to medical therapy, they think you as a surgeon are a hero. And if they have a poor response, or more commonly now, side effects that are very unpleasant from the dopamine agonists, they'll think you're a hero and be happy to have you take out the pituitary tumor. So this is actually something that's changing in endoscopic surgery now, in that we're operating in as an initial treatment in many patients with small prolactinomas, and we're having a very good result. In our case, 94% remission. Now, Cushing's has, I think we will all agree, is the most difficult and worrisome entity that we trust. This disease is really awful, and it has so many different manifestations. And there are so many patients who have some of the features, but not all of them, and may not really have Cushing's disease. So please always consult with your endocrine colleagues and make sure that the diagnosis of Cushing's disease is secure before you operate on these patients. Petrosal sinus sampling was mentioned. It is helpful, but it may be misleading. Remember that it does not make the diagnosis of Cushing's disease. First, you make that diagnosis, then you can do the petrosal sinus sampling in order to have some indication of where the tumor might be located from one side to the other within the sella. It's something we use infrequently now, provided that all the other diagnostic features are correct. Patients with Cushing's do not need preoperative or intraoperative steroids. If you give them, then you can't tell for days whether the patient has entered remission. So we give them no cortisol and measure the cortisone in the morning every day for 3 or 4 days in the hopes that it will be very low as a result of removing the corticotrope tumor. If the Cushing's tumor right after surgery has a thorough removal and does not what we call crash, that is, develop symptoms that are very much like the flu of fatigue and headache and just malaise, if they don't have those features at least for a day or two, they probably won't go into remission. So we like to see that. We monitor them carefully, and we've not had any difficulty with them getting in trouble from adrenal insufficiency. Now, we learned from Rudolf Albusch that these patients with Cushing's disease have hypercoagulability, and the complications in patients with Cushing's are much higher for deep venous thrombosis than in other patients. In my career, we've had one case who died, and she had a deep venous thrombosis and a pulmonary embolus. We've also been very careful with sodium in those patients. Now, this is a grossly invasive pituitary macroadenoma, and we studied over 400 patients looking at the dura of these patients microscopically, and we discovered that almost 80% of patients with a tumor like this will have invasion of the dura. In my mind, that means that we always leave some of this invaded dura behind, and therefore recurrences are frequent in those patients who have partial removals of macroadenomas. And in those cases, Gamma knife or other forms of focused radiosurgery are helpful in preventing recurrences. Remember that a Rathke's cleft cyst, like this one, when you open it, looks like an abscess in some cases. It may look exactly like purulence or pus. That is typical of ordinary Rathke cleft cysts, and several of these have been reported as, quote, silent, unquote, sterile abscesses in the sella. They're not. They are Rathke cysts and must be treated in the same manner as other typical Rathke cysts. If there's no bone or cartilage for reconstructing the sellar floor, and you need to because of a spinal fluid leak or to prevent further complications, sometimes I use a little plastic piece of macropore. We no longer use the tantalum mesh, but it's also another option for closure of the bony defect in the sella. We discovered that in postoperative management, immediate postoperative management, we no longer do immediate MRI or CT scanning. The most important thing is a visual examination of the patient. They're the best guide to any significant postoperative problem. And so we've not relied on a lot of postoperative imaging studies in the immediate postoperative state. Now, what we do in the immediate postoperative state is take the patient back to the surgery if there is a postoperative spinal fluid leak. Again, rather than use lumbar drain or other measures in order to stop a brisk spinal fluid leak, we simply take the patient back to surgery. We often do it quickly with a microscope because everything is exposed, and we just reconstruct the floor of the sella. And that has been very effective in stopping the rare CSF leak in our practice. Now, I talked about electrolytes and their management postoperatively, and the most important one is delayed hyponatremia, which can occur in as many as 10% of patients. And we have tried to avoid this completely because, as you know, rapid repletion of saline and salt can produce a very difficult problem, which is central pontine myelinolysis, or sometimes even extrapontine myelinolysis, where the brain gets demyelinated and can be quite fatal. So in every case now that might be prone to develop postoperative hyponatremia, we put them on a fluid restriction for 5 to 6 days after surgery. And that has been basically 100% effective in avoiding postoperative hyponatremia. This is a picture of central pontine myelinolysis. One Cushing's patient went to a rural hospital, was corrected in 30 minutes, I'm sorry, in less than 30 minutes, and developed this awful disease, which was fatal. Remember, some hypopit patients may not absorb oral steroids, so always give it parenterally if you're concerned about that. You know that they receive their steroids if you give it intravenously or subcutaneously. And postoperatively, when patients call and say they're unwell, it's almost always because of a cortisol deficiency or sodium disturbances. So in the emergency room, tell them to obtain a serum cortisol and a serum sodium, and that usually gives you the answer to the problem. We don't do post-op MRIs until 3 months after surgery. That's how long it takes for the surgical injury to repair itself. And we've stuck with that, and it's been very helpful to do a 3-month post-op scan. The other thing you have to have is a friendly ENT colleague, otorhinolaryngologist, who can help you with septal perforations, as you see here, sinus disease, postoperative epistaxis, or dealing with more complex anatomy. I've never had to take but once a turbinate process, and that's because I've had good help with my ENT colleagues. We do use radiosurgery after failed transsphenoidal surgery or recurrences. It's been highly effective in acromegaly and in prolactinomas, and it's been quite safe except for the complication of hypopituitarism that occurs in about 30 to 40% of our patients. Compulsive follow-up is necessary because these tumors recur. You all know that. So we can see it at 10 years. So we see them regularly. We measure their hormones and we do imaging if it's necessary because of their symptoms. You must recognize, this is my last slide now, of commonly recurrent invasive tumor subtypes. These must be monitored even more carefully. The silent ACTH tumor, the acidophil stem cell tumor, the plurihormonal tumor from different stem cell lineages, and the ACTH tumors in Nelson syndrome. These are bad actors and need to be followed and treated aggressively. And this is where Dr. Cushing went in 1912 to begin his series of transsphenoidal surgery for pituitary disease. We worked there in this office, which now was taken over by the administration, and we have a nice new building. But this is where much of it started, and it's been a pleasure to work there, and it's a pleasure to have been with all of these friends and colleagues who are at this wonderful meeting. Thank you so very much. Bye.
Thank you very much, Professor Lowe's, on that vast experience you have gathered and taught us all this information. I still use the needle whenever it's needed to make sure I'm not in the vessels on the cavernous sites or an aneurysm. I might lead one question. What is your take about functional pituitary adenoma that invade the medial wall of the cavernous sinus? Do you recommend to go after it? Because I've seen several presentations from the previous committee webinar on the neuroendoscopy. The people with the endoscopy, they take some, but there's still a good percentage left, and they end giving the patient gamma knife, but added the morbidity that I feel is underreported, especially when it comes to the cranial nerve and the vascular injury. Please tell us from your experience, how many times you do that?
Well, it's a difficult issue. I think we have all regained a lot of knowledge about the cavernous sinus, about its anatomy, and about the mechanisms of tumor invading the cavernous sinus through a puncture hole or actually invading the dural leaves of the cavernous sinus. Some people recommend, as you saw, resecting the medial wall of the cavernous sinus. For me, I know from the studies we've done before that we leave tumor behind no matter how careful we are, no matter how meticulous you are, you're still going to leave, and I said this to Vinko Dolek many years, you still are going to leave active tumor cells behind. So I think you can protect the carotid artery by decompressing the cavernous sinus. I think you can do the removal of easily accessible tumor with careful technique and good visualization. But how often we cure them, I think, is still a real problem. And to take any chances of damaging the carotid artery or the cranial nerves, I think, is not in the best interest of the patients.
Thank you. Any comment or question? Yeah, unmute yourself, Professor Najia.
Professor Edward, thank you so much for this amazing presentation and amazing experience, and I'm very great honor to be today with you in this panel. And my question, because I agree, I understand that you move to the endoscopy. We tell us with the Pablo. I don't know in how many years, but my question is, when you move from microsurgery to endoscopic, as master, as expert, as you, was it difficult, frustration in the beginning or not? Because I know when we are more younger, it's we continue even if it's difficult. But when we are used to perform the same technique for many years, it's not. I think it's not easy. What's your opinion, please, Professor?
I think your points are very well taken. It does take experience. It takes a methodological approach to the issue. So the approaches are, first of all, to remove the cellular contents away from the mesial wall of the cavernous sinus to to visualize it. As you know, the cavernous sinus is not just one big hole. It has many leaves of dura within it. And some of those leaves of dura cover the cranial nerves. They may cover the carotid artery. They may have separate areas themselves of bleeding. So you must first view the mesial wall of the cavernous sinus. The other issue is, is it possible safely to remove the bone over the carotid canal? If you can do that, even tumors that go all the way down the cavernous sinus, you can find them and selectively remove them from the carotid. Most of the time, the carotid adventitia is not invaded by these tumors. It can be. I've seen that, but it's very, very rare. So you can carefully manipulate tumor away from the carotid artery. You can carefully remove it from over the leaves of the cavernous sinus that protect the cranial nerves. And that's what I do. And you have the benefit of an angled endoscope so that you can actually see the perimeter of the tumor more readily than we could before with the direct view of the microscope.